I'll talk about screening and brief interventions. This is a little bit different aspect of management of substance use and substance use disorders. And there are some figures about the scope of substance use in the world. It's almost 2 billion people use alcohol, more than 1 billion use tobacco, 250 million use drugs, and apparently we don't have any expectations that the scope of substance use will diminish in the years to come, so it will continue to be a significant problem. And also, as we heard from the presentation this morning, that intensity of substance use may in fact increase. In the presentation this morning from Aaron White, I think it was very clear that the health effects and the impact on health and social services due to substance use is not always related to substance use disorders or to substance dependence. A lot of effects are related to intoxicating effects of psychoactive substances and basically to short-term acute toxic effects or the effects mediated by intoxication states, like, for example, injuries. If we look at the disease burden attributable to alcohol use, you will see that a lot of conditions which, in fact, constitute a burden of alcohol problems on the population's health is related to injuries, for example, which is this one, very big bulk of that, and many of these injuries are mediated by intoxication state and not by dependence as such. A lot is cardiovascular conditions, gastrointestinal conditions, and only approximately 1/3 we can assign in terms of causality to alcohol dependence. Though, of course, there are a lot of overlaps, but the message is that if we want to reduce the burden on health systems due to substance use, we need to address substance use at the continuum of substance use, from sporadic use, experimental use, to severe cases of dependence. So this basically the well-known pyramid, which is in different forms, traveling from one book to another, from one publication to another, and one presentation to another. So it's not original, but basically it conveys the same message. Substance use occurs on the continuum, from lower risk, from abstention, very low risk consumption levels and patterns, to higher risk associated with dependence on these substances. And that's why we know very well the interventions. They are established for years for dependence. They are well studied. Where it comes to lower and moderate risk, in WHO nomenclature, it's called hazardous or harmful use. So hazardous when there are no harms, only a risk of harms to health associated with particular patterns of or level of substance use, or the pattern of use which already resulted in harm to health, which is defined as a harmful use. We need to develop some procedures which will be able to address these levels of substance use and which are different from management of substance dependence. Basically, these are the rationale for introducing the concept of screening and brief interventions with public health objectives in mind. So this is a more detailed version of the same pyramid, which shows more gradients of intensity of substance use and health consequences, from very severe dependence to abstinent states on people who are not using any drugs. In fact, it's always some sort of a news for many audiences that more than a half of adult population in fact is not using alcohol in the last 12 months. So abstention is a significant phenomenon in the population, in the whole populations. So that's why at this level we need primary prevention efforts. But when it comes to hazardous use, when it comes to very sporadic episodic use, what are the interventions which at least may have prevention and management potential? So the answer, at least at the moment, is that this is screening and brief interventions with all the problems that I'll try to address in this talk. So what is in our manuals? We define screening and brief intervention their aim to identify current or potential problems with substance use and motivate those at risk to change their substance use behavior by creating a connection for the client between their current pattern of use and the associated risks and harms. In general, brief interventions in primary care can range from 3 minutes of brief feedback and advice to 15-30 minutes of brief counseling. Our focus is on health care, on health professionals, because these are the group of professionals who have authority and who have good opportunities to intervene in substance use whenever they identify substance use and have a willingness and opportunity to intervene. So, first step is screening. If to talk about the screening, for those of you who work in health systems, you know many types of screening for different conditions. And there are different types of screening, which for substance use might be applicable in different contexts, in different settings. Different types of screening might be applicable. From systematic screening, which can be universal, all patients, clients, and this kind of screening makes sense for substance use only in very high prevalence settings. For example, in mental health services, it definitely is needed, but it would be probably not very appropriate or very cost-effective to do the systematic screening, universal screening in low prevalence settings. Targeted, for example, for all patients, clients with particular conditions. Or semi-systematic or selective screening when the health professionals have signs or symptoms which indicate the higher probability of substance use at its hazardous or harmful patterns. And then this kind of screening is very much appropriate in many healthcare settings. And the last one is non-systematic screening when a practitioner feels it's natural to do so based on clinical judgment and clinical assessment of the situation with the patient. What are the prerequisites for effective and cost-effective screening programs? First, health conditions should be of significant public health importance. They should be associated with higher mortality or disability and higher health and social costs. In fact, when we are talking about the substance use, this condition can be met, this requirement, because I think in all this audience, we don't need to discuss how important it is to prevent and manage substance use and substance use disorders. It should be sufficiently high prevalence of target disorder or health condition in the population. And I think when we are talking about all psychoactive substances, not specifically about stimulants or opioids, but when we include tobacco and alcohol, this condition is definitely fully met. It should be higher effectiveness of prevention treatment interventions at early stages of a disorder condition targeted by screening. Here we have some issues. At the same time, we know from clinical medicine that, in fact, at early stages of diagnosis, it's almost a common rule that you have more opportunities for better clinical outcomes than at the advanced stages of any disease. So though in substance use disorders, I think the number of studies addressing these particular issues is definitely not sufficient. And the last point is the availability of screening instruments with adequate sensitivity, specificity, and predictive value, which are easily administered at low cost and have a high acceptability, both by health or social professionals and patients. WHO for more than 25 years promotes screening and brief interventions for alcohol use. With this audit and brief intervention manuals and with the audit instrument, which is widely used across the globe, it is available almost in all languages, it's being used in different healthcare settings. The audit C, a very short 3-question variant of the audit, is being even more widely used. In terms of effectiveness of brief interventions, we can say that the effect is small but quite consistent across different conditions. So that's why to achieve a public health impact, you need a higher coverage of screening and brief interventions for alcohol problems, even at the level of a relatively small effect on substance use. When it comes to the drug use, the World Health Organization developed another screening test, which also now is being more and more widely used across the globe, which is called the Alcohol, Smoking, and Substance Involvement Screening Test. In this test there, which is copyrighted by WHO, there are two advantages. One, it covers all psychoactive substances, from tobacco to different types of street drugs, with the possibility to include new psychoactive substances as they emerge in the scope of the assist. The second advantage of this instrument, that it allows to assess quantitatively a level of risk associated with substance use and plan interventions based on the level of risk associated with pattern or level of substance use of particular drugs in a client. That was a long process. As you can probably notice, that in all WHO products, our processes are so regulated that it takes some time to come up to the final product. And but at the same time, it was developed. It was not only developed, and its feasibility and applicability was tested in different cultures, but also we did a randomized controlled trial, which looked. This is the final product, which contains of 3 manuals. One is on the assist itself, one on brief interventions, and one self-help strategies for which brochure that can be given out to patients. These are the levels of risk, and here already the experience of using assist tells us that we may to revisit this table and to look at what modifications we can make in this. For example, with higher risk level, when this referral to treatment is a recommendation, whereas some recent evidence from some recent studies indicate that initiating on the spot treatment might be a much better strategy, which may increase the overall impact of screening and brief intervention procedures. Also, the question is to what extent appropriate to have this kind of threshold for studying screening and brief interventions, because these 3, in some cases, we may lower this threshold for screening and brief interventions in future. So again, this is the process, in the process of development, and these are the questions that we still need to address. What is the brief interventions, in fact? What is it? Basically, it's based on the principles of motivational interviewing, which I will not go into details of that, but many of you are familiar with this, and there are a lot of training packages developed based on the assist, on the brief interventions in general, which use the same principle. In the assist-related linked brief interventions, we use FRAMES, which consists of feedback, responsibility to the client, advice, menu of options for the client, showing empathy and emphasizing self-efficacy. These are the results of the multi-site international study of effectiveness, a randomized controlled trial of effectiveness of brief interventions. We published this report in 2008 as WHO report in 2011 in addiction. But basically, it was done in 4 countries, India, Brazil, US, and Australia, and it showed consistent effect. It's pooled results of brief interventions in comparison with the control. However, the clinical significance of these changes is questioned, and in fact, the changes in terms of days of not using drugs and levels of use, there are some questions that we still face. It's widely used in the US, for example, and some other countries, and this is the modification of assist done by NIDA, and which is being used in SAMHSA. And what I want to emphasize is that recently there is under Affordable Care Act, there is a possibility of funding of screening and brief interventions and compensation in the US, which is definitely a unique development by the government of the United States, and this is something that needs to hopefully would be addressed in similar level, or at least an attempt to do that in other jurisdictions. The screening and brief interventions are included, brief interventions in MH gap, which is one of the flagman recommendations for management of mental and substance use disorders by WHO. And this intervention guide has a special section on drug use disorders where brief interventions is part of overall management strategies when it's appropriate. Now we are in the process of developing a brief version of the assist because it's still quite long. It's an 8-question instrument, and now we are in the process of testing of the brief version, which is reduced to 2 questions, and we hope that it will improve its take-up by health systems. At the same time, when it comes to the effectiveness of brief interventions for drug use, there were several studies, including a systematic review on brief interventions in substance use published in 2014, as well as several recent studies, including the brief interventions for substance use in emergency rooms, which question the effectiveness of and efficacy of brief interventions for drug use. In fact, indeed, we cannot say now definitely, based on the randomized control trials and research done, that brief interventions for illicit drug use in different settings, including emergency rooms, has unequivocal evidence of effectiveness. What are the implications of that? First of all, let me list some of the issues which may be behind that. Clinical heterogeneity of target population. Control group differs from situations when substance use is ignored in patients, clients, when nothing is done at all. And in randomized control trials, ethical committees simply doesn't allow that to do. Modes of implementation of screening and brief interventions, physicians versus research and medical assistants, web-based interventions, clinical context, all these factors modify the results, and it might be too expensive to do randomized control trials involving physicians. Health outcomes in effectiveness trials. We are focusing on reduction of substance use, whereas it's very much legitimate to ask about other health outcomes, for example, maintenance and support of non-use in those clients who don't use psychoactive substances as a result of the screening, or effectiveness of interventions at keeping the low risk of substance use, or the patterns, or modifying the patterns and context of drug use. These are the issues that need still to be addressed in research to have the final decisions around the applicability and public health utility of these approaches. At the same time, we are quite confident in the World Health Organization that screening and brief interventions have a public health potential, public health utility, and should be implemented not on a universal basis, but should be implemented in healthcare settings. And let me list just several arguments for that. First of all, knowledge about patients' psychoactive substance use, including alcohol, tobacco, is important, is critical sometimes for diagnosis, clinical management, and long-term prevention and treatment. Based on the results of screening, objectives of interventions can be not limited to reducing substance use, but again, reinforcing abstinence, initiating treatment in case of diagnosed substance use disorder. Its opportunity to provide scientifically sound information on substance use and health tailored to the patient individual profile and context. And continued attention to patterns and levels of substance use is expected to facilitate early diagnosis and treatment of substance use disorders in future. Also, there is a question of sustainable development goals and the health target to strengthen the prevention of treatment of substance abuse, to increase the treatment coverage. You cannot rely upon development of specialized services. It's simply not feasible. You need to integrate management, identification of substance use and substance use disorders in broad range of settings, of healthcare settings, and health professionals should have the ability to do that. In summary, drug use occurs upon a continuum of use. Both moderate and higher risk substance use place a significant burden on public health systems. Screening provides an opportunity for education and can be used as a health promotion and secondary prevention strategy when we talk about brief interventions to improve the health of populations and individuals. Health professionals should be competent with identification and management of substance use in their patients across a continuum of substance use, from hazardous patterns to substance dependence. Screening for substance use and interventions as appropriate are prerequisites for increased coverage of prevention and treatment for substance use disorders. Thank you very much. That's it.